Hello, good morning from all of us here at the African Union and the Africa CDC, and welcome to this usual Thursday morning press briefing, where we are joined by Dr. John Nkengasong, who is the director of the Africa CDC. As usual, he'll be taking us through the situation of COVID-19 on our continent and then taking your questions at the end of it all. But for you to be able to ask your questions, please use the following WhatsApp number, +251 9455 2310, +251 945 502 310. You may also want to use the live platform or the question and answer session when we get to that. Now we are coming through to you on the African Union channels, and those include Facebook, YouTube, and the live stream. From the Africa CDC side, you can also join us on Facebook and on YouTube. And we are coming to you in English and French for the moment. Now, this is a press briefing, so we really welcome questions from members of the media. If we have any other people who are listening in to our briefing, please kindly let the media ask their questions first. All right, so now it's time for me to hand you over to Dr. John Nkengasong, the director of the Africa CDC, for his briefing. Dr. John, good morning, and you have the floor.
Good morning, Wayne, and greetings to all of our colleagues who are online from Addis Ababa. Let me first of all start by acknowledging the sacrifices, the tremendous sacrifices that our frontline workers continue to invest in this struggle against the COVID-19 response across the continent. And of course, appreciate the tremendous contribution that the media have been working with us since the start of this pandemic to transmit the accurate information and, of course, mobilize the community. As we do every week, we will do an update on the epidemiological situation and then focus on some of the things that Africa CDC is doing, and then conclude with an update on the vaccine situation. So first of all, the epidemiological update. As of 9 a.m. East African time today, the world has recorded over 106 million cases of COVID-19 infection and more than 2.3 million deaths, resulting in a case fatality rate of 2.2%. In Africa, amongst all 55 member states, we've recorded 3.7 million cases of COVID-19, representing about 3.5% of total cases reported globally. Of that number, 3.2 million have recovered, and this represents a recovery rate of 88%. Unfortunately, 96,000 individuals have died, that is of the 3.7 million, and this represents a case fatality rate of 2.6%, which is again still about 0.4 points higher than the global average. 5 member states have reported the presence of the 501Y V1 variant, and this is the variant that was initially reported in the UK. And these 5 countries include Ghana, Morocco, Gambia, Nigeria, and Senegal. 7 member states have also reported the 501Y V2 variant. This is what is commonly known as, this is the variant that was initially identified and reported in South Africa. And the 7 countries include Botswana, Comoros, Ghana, Kenya, Mozambique, South Africa, and Zambia. 5 countries that are accounting for more than close to 70% of the cases: South Africa with about 40%, Morocco 13%, Tunisia 6%, Egypt 5%, and Ethiopia 4%. In terms of the case fatality rate, over the last week, there were 2 additional countries that were added to the list of last week for a total of 20 countries, or 36% of the countries that are now reporting a case fatality rate of over 2.2%. The 2.2%, again, is a benchmark of where the global average is. So, in terms of the changes, we look at the epidemiological week 5, that is the week between 1st to the 7th of February this year. The continent recorded 99,710 new cases and 4,102 new deaths were reported. So in terms of the new cases, it represents 25% decrease in cases. And in terms of death, that number represents 28% decrease in deaths over the previous week. So that is very good news, very encouraging news. We all wish that that trend continues. The highest proportion of new cases reported for this week were from Southern Africa, 45%, followed by North Africa, 23%, West Africa, 19%, East Africa, 9%, and Central Africa, 3%. 5 countries that reported the highest number of new cases include South Africa with 22,000 cases, Nigeria 8.5 thousand cases, Zambia 8.5 thousand cases, Tunisia 7.7 thousand cases, and Mozambique about 6,000 cases. So if we now look at the last 4 weeks and ask ourselves the question, what changes have occurred, then we see the following trend. That is between January 11 and February 7. Overall, there has been an 18% average decrease. Remember, this is average decrease the last 4 weeks in new cases in Africa. And if you look at the different regions, they include 13% decrease in North Africa, 26% decrease in Southern Africa, where a lot of drastic decrease is happening there. But a 14% increase in Central Africa, 22% increase in East Africa, and a 5% in Western Africa. If you sum all of this, you have an average decrease of 18%. So if we now look at over the last 4 epidemiological weeks, we notice the following trends in the most populous countries in Africa. We observed that South Africa has recorded a 35% decrease in new cases, Egypt 17% average decrease, DRC a 6% average decrease, Kenya 5% average decrease, and Nigeria an average of 0.2% decrease. In terms of new deaths over the last 4 weeks, we noticed that South Africa has reported or is reporting 11% average decrease, Kenya 6% average decrease, Egypt 4% average decrease, Nigeria 31% average increase, and DRC 5% average increase. In terms of testing, as a continent, we are recording cumulatively 32 million cases tests conducted since this pandemic started. Let me now segue to the vaccines, and with a focus on the AstraZeneca vaccine and the story that we've all read this week in South Africa. And I will just walk you through what we know and then what our recommendations. So on February 7, 2021, the South African government announced a temporary hold to the rollout of the AstraZeneca vaccine, which was manufactured by the Serum Institute in India, following reports that the vaccine only offered minimal protection against mild and moderate cases of COVID-19 infection. This was based on a placebo-controlled phase 1 and 2 trial conducted by the team at the University of Witwatersrand, South Africa. conducted in collaboration with the Oxford University. The study recruited 2,000 relatively healthy and young volunteers with a median age of 31 years, with very few comorbidities. The aim of the trial was to assess the safety, immunogenicity, and efficacy of the AstraZeneca vaccine for the prevention of COVID-19 caused by the predominantly circulating new SARS-CoV-2 variant, that is the N501B.V2, or commonly called the B1351 variant. The efficacy of the vaccine against mild and moderate COVID disease, defined as at least one symptom of COVID-19, was 21.9%. This efficacy was below the minimum efficacy threshold of 50% recommended by the emergency use of vaccine candidate. Viral neutralization induced by sera from vaccine against the new variant was reduced when compared to the previous variant of the coronavirus. And protection against moderate to severe disease, hospitalization, and deaths could not be assessed in this study as the target population were at low risk. Again, the median age in this group, the study group, was 31 years. On February 9, 2021, the Africa Centers for Disease Control and Prevention convened a special session of the African Task Force for COVID-19 to review existing data and evidence and made the following recommendation. One, that for countries that have not reported the circulation of the SARS-CoV-2 variant, that is the N501YB2 variant, we recommend that they proceed with the rollout of the AstraZeneca vaccine. And if you all recall, the initial studies that were done reported an efficacy of 66% of this vaccine, which is above the 50% threshold. Second recommendation from Africa CDC, for countries that have reported the circulation of the SARS-CoV-2 variant, we recommend the acceleration of their preparedness to introduce all vaccines that have received emergency use authorization or approval by the regulatory authorities. Consideration should be given to the effectiveness of the vaccine against the variant, that is the N501B.V2 variant, or any other circulating SARS-CoV-2 variants in the country. All countries are then expected to expand their capacity or capabilities to conduct a genomic sequencing surveillance. And Africa CDC can support this effort. We have, through our Africa CDC Pathogen Genomic Initiative, we can and are in the process of supporting countries to generate more genomic sequencing in the context of surveillance. Our target is to generate about 50,000 genomic sequencing in the next coming months, so that we better understand the lay of the land with respect to the new variant. And lastly, that all countries should continue to generate data on the safety and efficacy of vaccine candidates in populations that are suspected to have this variant, so that we generate very quickly data that will inform us on the rollout. So let me end by just giving you a very quick update on the Ebola situation in DRC, which I will call the 12th Ebola virus disease outbreak in the Democratic Republic of Congo. The government of DRC reported on 7 February and the 12th outbreak of the Ebola virus disease in Butembo area in North Kivu province. Since then, more than 70 contacts have been registered and are being followed. So these are not cases, but contacts that are being traced. The government of DRC, through the Ministry of Health, is working with partners including Africa CDC to establish a coordination and response mechanism that will help contain the outbreak as quickly as possible. So as you can see, this is very early, and we have a team in country, the Africa CDC in country staff that will be supporting the government to look into this 12 outbreak. So thank you, Wayne. Let me return the microphone to you.
Thank you very much for that briefing, John. And we move straight into our questions. The first one is coming from Coletta Wanjohi with FSN. And Coletta says, following South Africa's decision to switch from AstraZeneca to Johnson & Johnson, does this cast a shadow on the usage of the vaccine in other parts of the continent, given that the recent COVAX allocations show that some countries are ready to receive AstraZeneca? So that's one question. She had a second one. Could you kindly speak to the just concluded African Union Summit's discussion on the idea of patents for COVID vaccines? So those are two questions from Coletta.
Yeah, sure. I think that all very good questions, Coletta, as always. So our recommendation for the use of the AstraZeneca vaccine is very clear. I mean that if you have evidence that the variant is the 501 V2 variant is dominant, the keyword here is predominant in the country, then we recommend that it should not be deployed there for the obvious reasons that we have, as we indicated, it will have reduced activities neutralizing antibodies as such. But for countries that have not identified this variant, there's absolutely no reason why it should not be used there. I think, again, remember that the threshold for any vaccine to be used is 50%. So I think we should encourage countries actually to use that vaccine where they do not have evidence of that variant. Having reported one or two cases in a country doesn't mean that the variant has dominated. We'll only be cautious in areas that have an extensive takeover of the pandemic by this variant. I think that is very clear. And we will today publish our guidance. I mean, all what I just explained to you will be put online so that you can extract as much as possible from that and we circulate it. And we count on all of your efforts to share that information with countries so that they should see what our position is. And I believe WHO just published similar guidelines yesterday. With respect to the AU summit that just ended, on patent issue, I think the AU is rallying itself around the call for a transfer of technology, the so-called TRIP, so that it can enable the continental manufacturing or transfer of technology. We know that we will be in this race for vaccine for long, and for several reasons. We truly are dealing with a new virus. We don't know that for how long, when people receive vaccines, the protection will last. And if it happens, it so happens, and just so happens, this is hypothetical, that the vaccines will require that we do periodic vaccinations. You also require that Africa is well positioned and equipped to be able to manufacture vaccines locally, so that or continent-wide, so that we can at least meet a demand. I mean, for a continent of 1.2 billion people. So it was a very much welcome move for the continent to apply its political weight behind the need for the transfer of technology through the WTO.
Thank you for that. Let's move online, and we have Esther Nakazi, who is on standby to ask a question. Esther, good morning. Please introduce yourself, your organization, and then ask your question.
Good morning. Thank you very much for this opportunity. And my question is about, one, Dr. John, how many countries have capacity to do genomic sequencing in Africa? Secondly, do we have Ebola in Tanzania? because there is a rumor of a strange disease, but we do not know whether it is Ebola or not. And then lastly, what happens to the countries that do not know whether they have the South African variant? What recommendations does the Africa CDC have for them? Thank you very much.
So, Esther, these are very excellent questions. In terms of countries that have the capacity, I'm tempted to name some, but in naming countries, you run the risk of omitting some of them. But so take it that what I'm going to say is not an extensive list of countries there, but at least for those that we are working closely with Africa CDC, we include South Africa, Kenya, Ethiopia, Morocco, Tunisia, Uganda, South Africa, DRC, Gabon, Nigeria, of course, Ghana, Senegal, and again, I run the risk of missing others there. So I think there is a growing capacity across the continent that we, Africa CDC, have supported to establish or to strengthen over the last 1 year in the area of genomics. So that is one. Second is that we have since last year established what we call the African CDC Pathogen Genomic Institute, which is a collection of laboratories or centers of excellence across the continent that work as a collective to address the issues of genomic sequencing. So from that perspective, we have this network going on, and Africa CDC is facilitating that countries that do not have the capacity to sequence to ship their specimens to countries that can sequence. Like I know that Cameroon has shipped samples to Nigeria, and within a week or two, they got their results, and many other countries are doing the same through the Africa CDC facilitation. So I think that much is going on as best as we can, and other countries continue to develop their own capacity. Concerning the Ebola in Tanzania, we have not received any alerts from Africa CDC, and we count on countries to report cases of any strange disease or Ebola if they are sure that the international community can work with them to respond appropriately.
Move on now. You've done both. Your hand is up, but you've also written down your questions. What do you prefer to do? Hello, good morning. Hello, good morning, Paul. Please go ahead with your questions, and you are from the Lancet.
Yeah. So my first question is, what is being done to test other COVID-19 vaccines for efficacy against the variant that the AstraZeneca vaccine is no longer very effective against? Then the second question is, I want to know whether the current level of genomic surveillance on the continent is reliable enough to conclude that countries that are not yet reporting the strain really do not have them, and not that they are not sequencing enough. While the last question I have is regarding the 12th Ebola outbreak in DRC. What new tools have been deployed in the latest outbreak, and what difference could they make in lowering Ebola's very high case fatality rate? Thank you very much.
So thank you, Paul. I mean, three very important questions. With respect to vaccine trials, as we speak, it's just yesterday that our network, which the consortium for vaccine clinical trials, met and agreed on the need to design a protocol that will begin to look at some of these the vaccines, not trials, actually testing these vaccines in different settings, including the AstraZeneca. Again, the AstraZeneca study in South Africa, we believe that more needs to be done to learn, to gain more insights into how that vaccine is working vis-a-vis that variant. So I think we will be working as a collective using our networks and the sites that we've established to facilitate that study. I think that will happen pretty quickly. We're hoping to start bringing together that network of the vaccine sites that we design to apply themselves to that common product. Second question about sequencing is, as I said multiple times, if you do not sequence, you will not find. So saying that if a country has not a sequence, of course, you cannot know if that the variant are in that country. So that is why the Pathogen Genomic Institute and the network that Africa CDC is promoting and coordinating is very important. That countries that do not have the capacity can work with us to generate enough sequences to understand the spread and extent of the virus in their country. In DRC, I remain very optimistic that we have better tools now in the theater of response for Ebola in DRC than ever before. As you know, there's now a licensed treatment and vaccines for against COVID-19. Against Ebola in DRC. Ebola in general, not just Ebola in DRC. And these are all tools that were not there previously. Okay? So I think that we just need to do the basic things, which is what we call the barefoot epidemiology. That is to find the contact and trace them where they are, and then, of course, do the ring vaccination. And for those that will be sick, I mean, you know that we now have the cocktails of antibodies that were developed in collaboration with Professor J.J. Muyembe. So the theater of response is richer than it was even a few years ago in DRC. So we just the challenge of finding the people and conducting the ring vaccination is what would drive and determine how quickly we bring that outbreak to a conclusion.
We move on now to a question about AstraZeneca vaccines. And this question is coming from Alex Winning, who is with the Reuters news agency. So he says, do the AstraZeneca trial results place AVAT's vaccine plan under threat, given that 100 million of the 270 million doses that have been secured are AstraZeneca doses? Is the Africa CDC looking to swap out AstraZeneca in its vaccine plan? In other words, are you looking to remove AstraZeneca from the Africa CDC vaccination plan? And also, are there many African Union member states that are seeking to sell or swap AstraZeneca doses?
So the answer there is that we are watching the situation in South Africa carefully, and also, as I said just now, that we will be conducting our own evaluations across multiple countries to see what the extent of the impact of that. So for now, our strategy is not to throw away 100 million vaccine doses, but rather target countries that, as we indicated in our recommendations, have not reported the case. I mean, cases of COVID, that specific variant. We are a continent of 55 member states. And all 55 member states are supposed to be part of the AVAC. And that means if you exclude those 7 countries or so that have reported that variant, you still have an extensive number of countries that those vaccines can benefit from those vaccines. So we will not be walking away from AstraZeneca vaccines at all. With respect to countries swapping those, I mean, again, countries have not, besides South Africa, I believe, and a few other countries, we have not yet seen countries acquire large doses of AstraZeneca vaccines that will require that they return them or they swap them. The 7 million vaccines that the MTN had supported, through the 25 million donation that they gave, were all targeting the AstraZeneca vaccine, and those vaccines will begin to be distributed in the coming 2 weeks or so. And we'll move ahead with that plan, and of course make sure that we target countries that have not reported those variants. There again, we need to do this quickly and vaccinate quickly to arrest the spread of this variant. So that plan will still move forward. And this is a good vaccine without the variant, and the variant will only impact if the variant is overwhelming in the country. So I think that is our recommendation on moving forward. Again, the 7 million doses of vaccines will target essentially for healthcare workers in all member states.
All right. Sarah Jerving with DEVEX has a very related question, and you've answered part of it. But she has the specific aspect where she says, are there any countries specifically that have told the Africa CDC that they no longer plan to roll out AstraZeneca vaccines?
The answer is no. We have not received any inquiries or concerns from member states that are have not expressed interest not to use the AstraZeneca vaccine. But we just don't know what the situation will be in the next coming days. So, but as of today, no member state has expressed any concerns with that.
All right. Sarah, good morning. I see you've raised your hand. Do you want to ask a different question, or has your issue been resolved?
A different question, please. Thank you.
Please go ahead.
Thank you. So just because there is no kind of minimal travel bans, won't all countries get the South Africa strain eventually? And would that mean that they would have to do multiple vaccination campaigns? And then kind of looking back to COVAX, since many of the countries were expecting the AstraZeneca vaccine in the coming months, does that mean delays in accessing vaccines through COVAX? Thank you.
No, I mean, if you look at the WHO guidance and our guidance, we're saying that countries that have not reported this, the variant should go ahead and continue to deploy the vaccines, and that will be our position. So if countries have placed those the orders from the COVAX, they should definitely move forward with that. Now, I just want to be very clear. Reporting a case or two in a country doesn't mean that that variant has overtaken the pandemic. I mean, because you really need to design these studies appropriately so that you can follow up using good epidemiological sampling to understand how it's changing, and understand also the background, what was initially there, so that you can understand how this new variant is dominated. But if the variant is only dictated in a few individuals, then there's absolutely no cause why you cannot use the AstraZeneca vaccine. I think that distinction is very important, because the narrative cannot be that you say in country X you tested thousands of samples, you found one case, and then you declare that country not eligible for use of the AstraZeneca vaccine. I think that would be a false narrative that is not what our recommendation is encouraging. So just to sum up, be sure we are absolutely clear on that. You need very appropriate epidemiologic studies where you follow up, you track the variant across over a given period of time to really see the changes. If you all recall that South Africa only could make that pronouncement because in October they noticed some changes, and then they kept sequencing over an extended period of time to December, and then realized that this variant was taking over there. So it wasn't just a punctual thing that they pick up a few individuals and then make that determination. So designing the study appropriately will give us the right answer if the variant is predominant or is not predominant in a given country.
Thank you very much, John. Let's welcome Joe Foster. Joe, good morning. I believe you are from the German News Agency. Hello, good morning.
Yes.
Hello, Joe. Can you hear us?
Good morning. Can you hear me?
Yes, I can hear you now. Please go ahead with your question.
I think my connection is bad. I'm not sure if you're able to hear me.
Right now we can hear you, so please proceed. Okay, it looks
Great.
like Joe is having...
Thank you. So my connection hasn't been great this morning. Just a question of clarification that only the countries where they're with... Sorry, are you...
Please go ahead.
Okay, I'm sorry if this question has been asked already. My connection's a bit bad this morning. So, Dr. Nkengazong, you said earlier that the Africa CDC recommends that only those countries where the variant, the South African variant is dominant, should not proceed with the rollout of the AstraZeneca vaccine. So of the 7 countries that you mentioned that have detected this variant, can you say which ones of those in which country of those is this variant actually dominant? Thank you.
No, that's a very good question. That's what my previous comments were really focused on that we should be very careful in the way we interpret this. That if country X sequence, you take 10 samples, you sequence it, and you find the one with the variant there, it doesn't mean it's dominant there. So none of these countries that I indicated have systematic studies over time that shows that the variant is dominant, has changed over a given period of time. I think until you do that and you follow up over time, you will not be very appropriate to characterize a country like dominant with that strain. Again, a cross-sectional study in one time point, and you pick 1 or 2 variants, that doesn't say that the variant is dominant in that country. That is all I'll say on that. So for those countries that we are reporting, it just means that they did maybe a survey, one time point, pick the variant, and that's all you can say at that point. It's a photograph of what they saw at that given moment.
All right, thank you for that. We move on to a question that's coming from Lawrence Caramel from Le Monde. And Lawrence says, how many tests have been done during the last week in Africa?
The last week, just give you that number. We've conducted, as a continent, 800,770 new tests were conducted over the last week.
You've probably already talked to is coming from Vinicius Assis from Brazil. And the question is, how many African countries have registered the 501YV2 variant of the coronavirus?
So I think 7 countries, as I indicated earlier, have reported that the new variant. Again, I know I'm repeating myself, just doing a cross-sectional survey and picking 1 or 2 samples that doesn't say that variant is predominant in that epidemic. The key word here is that variant predominant in that country? Is it driving the pandemic? So the 7 countries that we indicated, as stated earlier, have just reported. Besides South Africa, of those countries, we have not seen extensive data that shows that the pandemic in those countries is being overwhelmed by the new variant.
All right. Elizabeth Merab has written in, and she says that South Africa had also reported that the batch of first vaccine doses had a short expiry date of April 2021. What does it mean with regards to vigilance on the batches coming into the continent? And what should countries do to ensure that their doses have adequate expiry dates? And also the last question, what is the timeline for the expiry? So that's Elizabeth Merab from The Nation Africa in Kenya.
So I think we have to, this is not just a South African issue, it's what we have to all agree across the board that vaccines that are shipped anywhere should have the appropriate expiring date that will allow for this quick update. In as much as countries are very keen, and we are also very keen to make sure that vaccination occurs quickly, it will be prudent that expiration dates are extensive enough to allow for at least a couple of months of vaccination, given the logistics of putting in vaccination centers and reaching out to people. So I've not seen the specifics of the South Africa situation. That is what you just described. But we would strongly appeal that when vaccines are shipped to the continent, that the expiration dates are factored in. Expiration date meaning that the vaccine should have a good shelf life that will allow the logistics of rollout to occur.
From RFE in Paris, and it is from Daniel Finan. So Daniel says, what updates do you have on the AVAT facility? How many countries have signed up so far? And what are the details of the delivery of supplies?
So, very good question. The AVAC, as of early this week, I don't have the updates as of yesterday, but as of early this week, about 20 countries had expressed the interest of ordering. Where the expression means they submitted the forms that we sent out to them and details of what vaccines they wanted. And of that, of the 20 countries, they have expressed an interest to order about 200 and above 200 million doses. I don't have the specific number there, but it's in the range of above 200 million doses of vaccine. So I think that is going on very well. We'll continue to update it. I think we should maybe include that as part of the weekly briefing so that we are very specific with the number of countries that have expressed the interest to order the vaccine. Now, the expression of interest, I emphasize that also means they have to concretize and finalize the financial arrangements with the Afri-Exim Bank, and then the orders will be delivered. So that is all I can say for them. The AVAC platform, which in my view is very encouraging to see 20 countries already express strong interest of the order with specifics of what they want to order.
Thank you, John. We have another question coming from David Pilling from the Financial Times. And David says, you have said that the case fatality rate is higher in several African countries than the global median. Does this not merely reflect a relative lack of testing on the continent?
I think it reflects many things. I mean, there are a couple of things we have said over and over that we know about this pandemic, and the things that we don't know. I mean, about what we certainly know is that the testing has improved a lot. I don't have the specific numbers, but next week I would like to go into the details of the testing so that we see the test ratio, the test per case ratio have really increased a lot. Are we testing everybody? No, we are not definitely testing everybody because the sero surveys are showing us that people might have been exposed more than what we are actually reporting in terms of the number of the molecular assays, which is a gold standard for testing. With respect to the deaths, of course, are we counting all the deaths on the continent? No, we are definitely not counting all the deaths, especially in the second wave. But are we seeing massive deaths occurring in communities? That I think not. We have not seen that. We've definitely know that. Let me put it this way: we now know, at least at individual level, I would say most people on the continent do know somebody who has died of COVID during this second wave than it was in the first wave. So the death rate has actually increased a lot. Another possibility, what we are seeing is that hospitals are being overwhelmed due to our health systems that are fragile, and taking care of these patients is becoming difficult. And because of that, of course, people die because of basic care. Oxygen is also another factor to put in here. The lack of adequate supply of oxygen in many care centers is also a factor that, again, we've talked about it over and over, and the need to improve that and build partnerships to supply oxygen. So key factors here include overwhelming health system, lack of oxygen, and of course, whether we are reporting enough.
Thank you. Some of our colleagues have come in with follow-up questions. So we'll take those coming from Alexander Winning, and he is with Reuters. So he has come back with two more questions. He says, does the Africa CDC anticipate that the rollout of vaccines on the African continent will be delayed because of the uncertainty over the AstraZeneca vaccine? Then the second question, is the Africa CDC speaking to Johnson & Johnson about increasing the number of doses that it will receive from that company?
So in terms of delay, no, the delay vaccination will not occur. Countries will be, as I said earlier, the next 2 weeks or so, the AstraZeneca vaccines will start arriving in the continent, especially those that were being purchased by the support from NTN. Those vaccines will continue. Are we in discussions with Johnson & Johnson? Yes. I mean, especially trying to get more doses from Johnson & Johnson as part of the AVAC efforts. I think that maybe the specifics have not been agreed on or nailed down, but the discussions are ongoing to have an increased number of some of the Johnson & Johnson vaccines.
All right. Paul Adepoju has two follow-up questions as well. And he says, has the number of African countries that have ordered for the COVID-19 vaccines on the Africa CDC platform increased since last week? I believe that you've already answered this. You said this week we are on 20, and last week I believe we were on 16.
Yeah.
So then he has a second question. What is the latest total number of countries and how many doses of the respective vaccines have been ordered so far on that platform?
So as I said, Paul, and Wayne already addressed your part A of the question, which is has the number increased? Yes, and who knows, it may have even increased further this last few days. So I'll leave that at that, and then we hope to come back to that next week. So with the specific of each country, if that is of interest, we'll plan to do that analysis for next week. As you can imagine, it's difficult for me to memorize the 20 countries that have placed the orders and which specific vaccines they place their orders in. But if that is of interest to this conversation, we'll prepare that for next week.
Thank you. We come back to Esther Nakazi. And she says, in terms of vaccine confidence, what is the Africa CDC doing to reassure Africa and Africans, especially at this moment, given the South African study?
So we are assuring Africans that these vaccines are safe. I mean, the vaccine confidence, let's be very clear that we do not mix two things, where we do not mix efficacy and safety. So all the vaccines that will be run through the continent through either COVAX or AVAC will be vaccines that are safe. Whether the vaccines end up being efficacious or not because of the variant is a separate question. I think, but we know from data that was published that the original findings suggested that these vaccines were efficacious. Again, we should also be looking at a key parameter here is, are these vaccines going to delay mortality and hospitalization? That is very, very important. If these vaccines And even if they do not prevent infections, delay mortality or reduce mortality and hospitalization, that would be great. So I think that would be a huge plus going forward. Remember, these are first generation vaccines, and we'll continue to learn from the virus and develop new vaccines as companies are already doing. So I think we will continue to learn how we use these vaccines and how they perform.
Okay, we have someone who's coming in for the first time, and that is Rhoda Odiambo. I believe, Rhoda, you're with the BBC. Please go ahead with your question.
Hi, Wayne. Yes. My question is to Dr. Nkegasong, and just following up on clarity. So, Dr. John, you mentioned that the recommendations from the African Union conference is that countries that have reported a dominant number of the South African variant, the recommendation was that they should not introduce the Oxford vaccine. So my question is, what is the threshold of numbers that countries should be looking at? Because I know Mozambique reported quite a lot of cases from this variant.
So again, Rhoda, I want to be very clear that you cannot do a one-time cross-sectional survey and then you address that question. It really has to be over time so that you see the changes. What was the initial variant or lineage, and then what is is this the variant taking over? I think until we see that kind of data, it will be very difficult to say that because we detected this variant out of some type of sampling to make that conclusion very early on. There are many methods of sampling that, just give you one example. If, for example, I did a sampling of a household, and then you don't control for whether that family you took samples from the same cluster of people, you may end up saying that virus predominates. But the key thing will be that virus was circulating within that household or that smaller community, and it will be difficult to extrapolate that to the entire community if this makes sense. So that is why systematic, appropriate design of studies is very important to teach us whether the virus is predominant or not. So it may end up being that it's the same family sharing virus, that same virus there, and then you report it as 7 cases there. So again, I really caution that we use appropriate design protocols to determine if the variant is predominant or not. I don't know that I can give you a threshold of whether if the variant is at a certain level, it is predominant or not. Only a prospective cohort follow-up sampling would tell us whether the sample that the variant has changed or has become predominant.
All right, thank you for that. We have a follow-up question from Daniel Finnan of RFE, and Daniel says, besides funding from Afreximbank to the tune of $2 billion, where is the rest of the money to buy vaccines coming from?
So there are 3 sources of support for vaccines. And one is individual countries doing their own vaccine acquisitions. And we know that some countries are doing it bilaterally, Egypt, Morocco, Guinea, and I'm sure others. Second is through the World Bank, the COVAX facility, which is really a source of subsidized vaccines, or say free of charge vaccines. And third, of course, is through the Africa Union platform, that is the AVAC. Maybe I should add the fourth. I said 3, but add the fourth. The World Bank has also, as you know, make an announcement that 12 billion was on the table, not for Africa, but the whole world. And of that, about 4 to 5 billion is targeting Africa. The countries have to express that. Those are not grants, those are loans, okay? Both the Afrexim Bank funds as well as the World Bank funds. The World Bank funding is really also designed to enable countries to roll out vaccines. So it's not just acquiring vaccines, but also rolling out vaccines. So again, it's not a grant or a donation, but it's long-term loans.
I think let's go to our final set of questions for today. And they're coming from Nibasumba Emil. And Nibasumba is a journalist at Radio Publique Africaine from Burundi. And she has two questions. The first one, Burundi will not get COVID-19 vaccines for the first phase, but it is among the low-income countries. Did it not ask for the vaccine? And what really happened with Burundi? So those are two parts to the first question. Then the second question, can you please explain the whole process for it to be decided that the vaccine against COVID-19 is sent to a country like Burundi? I think what she's saying there is, please explain how the decision is made for vaccines to be sent to countries like Burundi.
So, very good question. I cannot address the specifics of what Burundi has done or not done. As you can imagine, that I'm not privileged to those negotiations at the country level. But the process for COVAX is simple. I mean, the countries are sovereign. They engage with Gavi. Again, COVAX is a mechanism that brings WHO, Gavi, and CEPI. CEPI is the Coalition for Epidemic Preparedness Innovation together. So they discuss directly with that facility. I mean, period. That is all they need to do. And then based on their level of where they are categorized as low income, middle income, or high income, they would have those discussions going forward there. So I think that's all I can tell you with that mechanism. With AVAC, is the same. The African Union mechanism is that we've shipped out all the materials that are required to countries. The forms have been sent to them. It's up to Burundi to go into the system and ask for their vaccines. And if you go into the amsp.africa, you actually can see the allocations of, and countries have access to that. They can see the allocations of how many vaccines are allocated to countries using very objective criteria, population size, maybe the pandemic and other factors there. We did this same exercise during the diagnostic. When we were having the diagnostic challenges, we arranged for the diagnostics, allocated them their quotas to countries, and the countries were able to go in and acquire their diagnostics. It's the same process and mechanism for the vaccines allocation. So Burundi, in short, can go into the platform. They have Africa CDC platform and source for their vaccines. I don't know what they have done with COVAX. I'm not privileged to those in-country discussions.
Okay, thank you for that. We have run out of time, but I can see that, Sarah, you have your hand up. Can I encourage you, please, to just write that question into Neke on that WhatsApp number +251 9455 0302310. Let me just give it to you again. +251 9455 02310. So please, Sarah, direct your question to Neke and he will be able to respond to you. But now it's time for us to have the last messages that Dr. John would want to leave with this press briefing, the main headline points that you want to give us, Dr. John.
So the couple of headline points, Winnie, is that we can prevent infections from this pandemic, given all the lessons and the tools that we have at our disposition. And clearly that if you look at the trends that I just reported, it shows that we know how to prevent the infection. Include, of course, that we continue to work with the community to improve and sustain the ability to wear masks, that we avoid large gatherings, of course. If we deny the virus space to spread, the virus will not spread. And that's why we see several countries are now bending the curve again during their second wave, and very nicely. And I really hope that next week we continue to have good reports over the last week. This is a tricky virus. We may come here next week and realize that we actually saw an upward trend. But I really hope that with the gains that we are making in that downward movement, essentially due to adherence to a good public health practice, will continue. I think that is the first case. In summary, let's go to war with what we have and not what we need. But the vaccine piece there, that vaccines are not a magic bullet. They will not be here anytime soon, meaning that in the next 1-2 months, that even if they are here, it will take time for the effect to get the effect of the vaccination to actually be felt in terms of decreasing number of infections and hospitalizations. So I think let's remain, keep working hard. All of us are working, the WHO, Africa CDC, Africa Union, and others, to get the vaccines to the, but again, discipline and adherence to public health measures should still be the gold standard for us to prevent this pandemic going forward. And lastly is that vaccines are safe. Okay? I will be the first person to get my vaccine shot if they were available. I have not yet had it just because we don't have it. And we are looking for vaccines to protect our frontline workers. So not just the healthcare workers, but like responders in the field. I mean, we are deploying Africa CDC, a large number of responders. Now we are actually in a difficult position to do that because of, because of the infection. So we continue to work with or look for vaccines that can enable us support our frontline workers as well as healthcare workers. So I think those are the two key messages, that I would like to leave this audience.
And I think that will be a great confidence booster. The fact that you will be among the first ones to take the vaccine once it hits our shores here in Africa. Thank you very much for that. Colleagues, this is the end of our press briefing for today. But before we go, let me just inform Dr. John of a compliment that has come through from Vidomu Aka. And Vidomu simply wants to say, very good meeting with a lot of information. So that's a nice comment. Thank you for that, Vidomu. Colleagues, this is the end of our briefing for today, but we will be back with you as usual at 11 a.m. East African time next week on Thursday. Bye-bye for now.
Thank you.